Other forms of simple partial seizures include those that cause changes in somatic sensations. Some patients describe odd internal feelings, which is called fear or deja vu, when precede a complex partial or secondary generalized seizures. These simple partial seizures serve as warning and is called as aura. The complex partial seizures, as we have discussed earlier, are the partial seizures that are associated with loss of consciousness. So it is a focal seizure activity. The patient is unable to respond to visual or verbal commands during seizure and has an impaired recollection of awareness or ictal phase. They frequently begin with an aura. The start of the ictal phase is often a sudden behavioral arrest or motionless stare, usually accompanied by automatism. The patient is typically confused following the seizure. The partial seizures with secondary generalization. The partial seizures can spread to involve both cerebral hemispheres and produce a generalized seizure, usually of tonic-clonic variety. It is often difficult to distinguish from a partially primary generalized seizures. A careful history identifies preceding aura. Now coming to generalized seizures, they arise from both cerebral hemispheres simultaneously. It is currently impossible to exclude entirely the existence of focal region of abnormal activity that initiates a seizure prior to secondary generalization. Generalized seizure is practically defined as bilateral, clinical, and electrographic events without any detectable focal onset. The generalized seizures, they are absence seizures, generalized tonic-clonic, atonic, and now we have absence seizures. The absence seizures are sudden, brief lapses of consciousness without loss of postural control. Typically last for only seconds. The consciousness returns as suddenly as it was lost. There is no post-ictal confusion. Absence seizures are usually accompanied by subtle bilateral motor signs like rapid blinking of eyelid, chewing movements, small amplitude clonic movements of the hand, and can occur hundreds of times per day. Always begin in childhood or early adolescence. The hyperventilation tends to provoke these seizures. But typical absence seizures are not associated with other neurological problems and respond well to treatment with specific anticonvulsants. The 60 to 70% will have a spontaneous remission during adolescence. A typical absence seizures, it is a lapse of consciousness, is usually of longer duration. It is less abrupt in onset and accompanied by more obvious motor signs. It is atypical absence seizures. So we see there are two types of absence seizures. One is typical absence seizures and one is atypical. The typical is associated with loss of consciousness but not associated with any other neurological problem, and 60 to 70% respond. Automatically, they remit over adolescence. And atypical absence seizures, either they are associated with obvious motor signs, loss of consciousness, and loss of or cessation of other neurological deficits. Now, generalized tonic-clonic seizures, grand mal, are the most common seizure type resulting from metabolic derangements. The initial phase of seizure is usually tonic contraction of muscles throughout the body. After 10 to 20, the tonic phase of the seizures typically evolve into clonic phase, produced by superimposition of period of muscle relaxation on tonic muscle constriction. The periods of relaxation progressively increase until the end of ictal phase. It usually lasts no more than 1 minute. The post-ictal phase is characterized by unresponsiveness, muscular flacidity, excessive salivation, and bladder to bowel incontinence. The patient gradually regains consciousness over minutes to hours, typically a period of post-ictal confusion, headache, fatigue, and muscle ache. Now coming to atonic seizures. Atonic seizures are seizures with sudden loss of postural muscle toning, lasting 1 to 2 seconds. The consciousness is briefly impaired and usually there is no post-ictal confusion. There is a very brief seizure may cause only a quick head drop or nodding movement. The longer seizures will cause the patient to collapse. They are extremely dangerous, atonic seizures, because the patients fall suddenly without any premonitory symptoms or without any alarming signs. Majority of the head traumas or head injuries that occur while driving or while swimming or like high risk activities, they are because of atonic seizures. Now, myoclonic seizure is a sudden and a brief muscle contraction that may involve one part of body of the entire body. The pathological myoclonus is most commonly seen in association with metabolic disorders, degenerative CNS diseases, or axonic brain injury. So most of the metabolic uh, the myoclonic seizures are sudden and brief muscle contractions that may involve one part of the body or entire body. The pathological myoclonus is most commonly seen in association with metabolic disorders, degenerative CNS changes, or axonal injury. Now coming to unclassified seizures. First is a neonatal seizures. The neonatal seizure occurs in less than 1 month. So basically, as we know the definition of neonate, a neonate is aged below 28 days. So these seizures also happen within 28 days of the life, first 28 months of life, 28 days of life. It is seen in one less than 1 month of age. It is brief episodes of apnea, eye deviation, eye blinking, or repetitive movements of arms and legs. Second type is infantile spasms. Infant is usually called a baby under 1 year of age. So these seizures happen before 1 year. It is associated with abrupt movement of head, trunk, or limbs. The classic spasm is sudden flexion of the neck and abdomen with extension of the limbs. If you see the patient of an infantile spasm, it, it seems like the baby is sudden fearful of something. He flexes his abdomen, limbs, and head as if someone has come to fear him. Evaluation of patients of epilepsy. Now, as we see, the epilepsy comprises of so many types of abnormal movements and combinations of abnormal movements, absent movements, loss of consciousness. So to summarize again, the epilepsy is generally classified as generalized seizures and partial seizures. Apart from these, there another class of epilepsy which we call as unclassified seizures, which comprises of myoclonic jerks of infantile spasms, neonatal spasms. Of generalized epilepsies, we have generalized tonic-clonic seizures, we have atonic seizures, myoclonic seizures, absence seizures, and infantile and hips arrhythmia. Of partial seizures, we have simple partial seizures, absent partial seizures, complex partial seizures. Of absence epilepsy, again we have a simple absence and a complex absence epilepsy associated with abnormal features. So if a patient comes to you with epilepsy, the first study we have to do is electrolytes, of which sodium and potassium are very important. Many of the patients that come to OPD or ICUs with epilepsy, they have electrolyte abnormalities. The electrolyte abnormalities are typically seen more commonly in ICU settings when the patient is brought to the ICU. On the OPD basis of patients, those who come to the OPD after seizures or just checkup and treatment, electrolyte abnormalities are less. So getting all electrolytes done is a mandatory protocol if a patient is admitted to ICU with seizures or a status epilepticus. Second is glucose estimation. Many of the diabetic patients, they take either excess insulin or drugs without accompanying meals. They'll end up in hypoglycemia. And hypoglycemia is also an important cause of seizures. It is also routine to measure sugar measurements for patients who are admitted to ICU. Now, amongst the large anions, calcium and magnesium, they both are leading cause of epilepsy. Very low levels of calcium, that is called as hypocalcemia, is associated with high incidence of seizures of all types. And serum calcium measurement is a protocol of ICU management. Similarly, hypomagnesemia is also a cause of seizures in ICU settings. And magnesium and phosphorus should be estimated in all patients coming to OPD ICU for seizures. As a routine liver function test, renal function tests, a urine analysis, and a toxicology screen for lead, arsenic, mercury, they are to be done to rule whether they are not the cause of epilepsy. If all these are normal and the patient is suspected of having either meningitis or some brain infection or subarachnoid hemorrhage, we usually go for a lumbar puncture. So, electrolyte estimation, glucose estimation, calcium estimation, magnesium estimation, or liver function test, renal function test, urine analysis, toxic screen, and lumbar puncture. They all are done in patients suspected of having a seizures or patient of seizure admitted in emergency department. Now coming to EEG. EEG is a very important topic in epilepsy because EEG is as such done in all patients of epilepsy, but there are 2-3 things that are essential to knowing regarding EEG, that EEG is not a diagnostic tool for epilepsy. A positive EEG, that is presence of or generalized or localized epileptiform activities, they may suggest the diagnosis of epilepsy if it is proved with other tests, and a abnormal EEG can be seen in a normal patient, and an epileptic patient can have a normal EEG. So EEG is generally used for quantification and classification of epilepsy and a syndromic diagnosis of epilepsy, because the syndrome responds better to a treatment as compared to non-syndromic epilepsies. Second is CT scan. If either MRI is not available, then we go for a CT scan to rule out a major bleed or tumors. Otherwise, CT is a very primary tool for investigation in epilepsy if other things are not available. MRI and a SPECT, they are the investigations of choice in epilepsy. All patients in epilepsy must get an MRI done with epilepsy protocol, which involves a detailed study of temporal lobes, hippocampal region to rule out medial temporal epilepsy, and a positive emission tomography scans or a diffusion scans to rule out, and a PET scan. A PET scan usually indicates that part of brain that is hyperactivated in epilepsy. So but before investigation the patient for epilepsy, we should also see what are the differential diagnosis of epilepsy, because not all abnormal movements, not all episodes of unconsciousness are epilepsies. The foremost and the first that I would keep in a diagnosis differential of epilepsy is a syncopal attack. The patient usually complains of a simple perspiration with hypoventilation and episodes of falling. It can mimic a absence seizure or atonic seizure, and syncope is a very common differential diagnosis of the typical of syncope is the patient is made to lie down, and if limbs are raised, the patient regains consciousness, or after a vagal massage regains the consciousness immediately, but this may not happen with seizure. Now, psychotic patients with abnormal psychosis or neurosis or conversion reactions, they also present like seizures. Metabolic disturbances, as we have earlier discussed, like hypocalcemia, hypomagnesemia, hypoglycemia, hypothermia, liver and renal function, they can present as epilepsies. Migraine is also a very important cause of differential diagnosis of epilepsy. A severe migrainous headache can cause the patient to become unconscious. It is called as epileptogenic migraine. And another term is migrainogenic epilepsies. They both are very close terms. Few epilepsies that present with headaches, and few headaches that present with unconsciousness epilepsies. The treatment of both is nearly the same, but has to be differentiated by all investigative means. Another differential diagnosis is transient ischemic attack. If there is a sudden cessation of blood flow to the cerebral cortex, the patient gets unconscious and falls down with or without loss of movement or sensation of one part of body. The TIA is an emergency, and it has to be differentiated earlier than, because it is a warning sign for stroke. So, a MRI or MR angio with CT angio or cerebral Dopplers or 2D echo studies are essential to rule out TIA. Many sleep disorders, they also present like nocturnal epilepsies. One of the most common syndromes of nocturnal epilepsy is benign nocturnal epilepsy with central spikes, and few sleep disorders also present with seizures. Movement disorders may also present like epilepsies, and they are also one of the very essential differential diagnoses. Now, coming to the treatment of epilepsies, there are so many drugs that are available for treatment in epilepsies. For partial epilepsies, we have carbamazepine, we have phenytoin, we have valproic acid, we have lamotrigine. For tonic-clonic seizures, we have valproic acid and lamotrigine. For absence seizures, we have ethosuximide, we have valproic acid. For myoclonic atonic, we have both valproic acid. So, as far the drug therapy of absence concerned, the older anti-epileptic drugs, which were carbamazepine, phenytoin, their use is now going down because of drug interactions, because of their ability to induce or suppress cytochrome enzyme oxidase, their teratogenic potentials, and their major side effects. The newer anti-epileptic drugs like lamotrigine, lacosamide, levetiracetam, topiramate, they are becoming more popular because they have no drug-to-drug interactions, they have very low side effects, they are less sedating, and their serum levels are easy to monitor, and multiple anti-epileptics can be given without significant drug actions. So it depends which type of epilepsy it is and what type of treatment the patient can afford and the patient can sustain without having substantial side effects. So this was all regarding the treatment and of the epilepsy. So I hope you all have understood this epilepsy, and this was a brief regarding epilepsy.